Hello and welcome to this educational activity entitled Expert Video Viewpoints on Castration-Resistant Prostate Cancer, Care Across the Continuum. I am Emmanuel Antonarakis, Assistant Professor of Oncology at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center, and I'm joined by Dr. Leonard Gomella, Chairman, Department of Urology, Associate Director of Clinical Affairs, Jefferson Kimmel Cancer Center at the Thomas Jefferson University, and Dr. A. Oliver Sartor, the Laborde Endowed Professor of Cancer Research at the Tulane University School of Medicine. We will now shift to Section 2, Metastatic Castration-Resistant Prostate Cancer Progression, and in this section we want to focus on what happens to the patient who progresses after docetaxel chemotherapy. And first of all, I'd like to turn to Dr. Sartor and ask him what kind of criteria he uses to define disease progression in a patient that has received docetaxel.
Well, there are three parameters really. We can utilize, of course, and the most important parameter, clinical progression. Patient is developing increasing pain, maybe the beginning of a decline in performance status. We have radiographic progression, that can either be bone scans or CAT scans, and we use biochemical progression. If the patient is having obvious biochemical progression, then I think we can consider changing therapy. Not within the first 3 cycles, because we don't want to get caught in a flare phenomenon, but after the patient has had 3 cycles and the PSA is clearly progressive, I think we can consider other therapies.
So really it's a very interesting time for us in the prostate cancer world. We have now 2 drugs that were specifically approved for patients that have failed docetaxel and progressed after docetaxel chemotherapy. The first is another chemotherapy agent called cabazitaxel. The second is actually a novel hormonal therapy called abiraterone, and we'll be discussing each of these in turn. First, I'd like to review the NCCN guidelines for the treatment of patients with docetaxel-resistant or refractory metastatic castration-resistant prostate cancer. And in this category, we have 2 agents that have level 1 evidence for their use, the first being cabazitaxel. The study was done specifically in the post-docetaxel space, and also an oral agent, abiraterone, also with level 1 evidence for that agent. Now, there are other things that people can use. Again, our old friend mitoxantrone can be used in these patients, although it will be used, I think, less and less with newly approved chemotherapies with level 1 evidence. As well, we have other secondary hormonal manipulations, palliative maneuvers for bone pain, etc. But I'd really like to begin with talking about the tropic trial, which was really a pivotal trial, and ask Dr. Sartor to describe this study.
Well, actually, it was fairly straightforward. It was for patients who had shown clear progression after docetaxel. And by the way, if you had radiographic disease that was measurable going into the trial, you had to have a measurable progression prior to trial entry. And the randomization was to cabazitaxel prednisone, and cabazitaxel was the novel taxane, which in vitro and in model systems had shown clear activity in the docetaxel-resistant setting. Compared to mitoxantrone prednisone, you might say, well, why mitoxantrone? There was no clear standard of care, and this was in a space where almost anything could have been used. In fact, so if we look at the abiraterone trial, they used prednisone alone. So, and then, by the way, other trials, they've used placebo. So the use of mitoxantrone prednisone was designed to bring some chemotherapy that had known palliative effect, and then to compare the cabazitaxel to the known chemotherapy. But the primary endpoint was overall survival.
Dr. Gomella, could you summarize the overall survival findings from the TROPIC study?
Well, in the TROPIC study, if you compare the mitoxantrone group with the cabazitaxel group, it was about 12.1 months versus 15.7 months. So there was clearly, again, about a little bit more than a 2-month survival advantage in the cabazitaxel.
So that sounds great to me, but how about some of the toxicities? Dr. Sartor, can you talk about some of the side effects, adverse events that were seen with this agent?
Sure. And every drug is a risk-benefit ratio, and there are clear risks associated with this drug. There was about a 7.5% risk of febrile neutropenia, which is pretty high, much higher than you see with docetaxel. In addition, there were some patients who had grade 3 diarrhea, and that's a substantial concern, particularly in an elderly patient on chemotherapy. Some fatigue, some nausea, some bone pain, not a lot there. The big 2 concerns that I had were the febrile neutropenia and the grade 3 diarrhea.
And I'd like to just summarize with some prescribing tips that I found helpful in my clinic. So just to clarify, the FDA approved dose for this agent is 25 milligrams per meter squared, given intravenously every 21 days, which is similar to docetaxel in the fact that it's every 3 weeks. In addition, this agent has to be combined with prednisone 5 milligrams by mouth twice daily, according to the FDA label. I usually like to give my patients IV pre-meds, and I usually use diphenhydramine as well as dexamethasone, ranitidine before the chemotherapy is given. This drug really is contraindicated in patients with hepatic failure. It's a taxane. It's actually cleared by the liver. So I would really avoid this in any patient that has elevation of bilirubin or other signs of hepatic failure. In addition, There's a question about GCSF. Should we use this to try to prevent some of the myelosuppression, the neutropenia? I think it's very important to note that the FDA has put that in their label that GCSF is encouraged. So I definitely use that, especially in my patients that are over the age of 65. And finally, just some drug interactions. This agent should be avoided with drugs that interact with CYP3A4, and specifically some of the azole antifungals. Some drugs like rifampin, as well as clarithromycin and phenytoin, should be avoided with this agent. And I'd now like to shift gears and talk about a novel hormonal therapy, namely abiraterone acetate. And I'd like Dr. Gomella to talk about the mechanism of action. How does this drug work?
Well, abiraterone is very interesting. It's the first in class. It's an androgen biosynthesis inhibitor, and essentially what it does, it interferes with the CYP17 pathway and interferes with the ultimate production of testosterone and testosterone precursors.
This has been a very interesting drug, and actually there's been a whole slew of phase 1 and phase 2 studies that were done almost concurrently with each other. It's really never happened before. I'd like Dr. Sartor just to summarize some of the phase 1 and phase 2 studies of this agent, abiraterone.
Well, first of all, when you're taking a new agent, your expectations are often pretty low. But as it turns out for abiraterone, the expectations turned into pretty high. And that's because the PSA responses were far greater than I think what most people would have anticipated. And it was interesting that these phase 1, phase 2 studies were done not only in the pre-docetaxel space, but also in the post-docetaxel space. And it was clearly and unequivocally shown that you could take a hormonal agent and induce responses even in patients who had had prior chemo. So this really raised the expectations for this particular drug and set the stage for the phase 3.
I'm glad you mentioned that. So again, very promising activity not only in the pre-docetaxel but also in the post-docetaxel setting. And this actually led to a phase 3 study named Cougar 301. Dr. Gomella, could you describe the trial design for this pivotal trial?
Well, the Cougar 301 was a 2-to-1 randomization of abiraterone and prednisone versus placebo and prednisone in patients with metastatic castrate-refractory prostate cancer.
And what do we know about the efficacy results from this pivotal study, Dr. Sartor?
Well, the wonderful news is it was positive. So the primary endpoint was overall survival. There was an unequivocal prolongation of overall survival. In fact, quite interestingly, it was stopped at the interim time point by the Data Monitoring Committee because it was so positive. The trial was never actually completed in its final design. It was stopped at the interim endpoint. And there was a median of about 10.9 months in the placebo at the time of the interim, 14.8 months for abiraterone. And there were a whole variety of secondary endpoints, such as time to PSA progression, that were also favorable.
Now, Dr. Gomella, what are the common toxicities with this agent you have to think about?
Well, because you're interfering with the CYP17 pathway, what you can end up with is sometimes a mineralocorticoid excess. So the things you might imagine with some edema, some hypokalemia, and some hypertension can be seen. Using prednisone will abrogate many of these side effect profiles that are caused by the excess mineralocorticoid caused by the CYP17 inhibition.
Again, I'd like to just talk about some prescribing pearls. So the dose of abiraterone acetate is 1,000 milligrams by mouth daily. It's actually provided as pills containing 250 milligrams, so patients have to take 4 pills daily. Again, just like the other second-line agent, cabazitaxel, this is also indicated in conjunction with prednisone, 5 milligrams twice daily. It's recommended that this agent is taken on an empty stomach. And in addition, again, with hepatic impairment, this is something that you should usually avoid, or at the very least, dose reduce. And the FDA package insert actually states that in any patient with even mild or moderate impairment of the hepatic function, the dose should actually go down to 250, which is 1/4 of the whole dose. In addition, because of this issue with some extra edema, patients that have heart failure, especially class 3, class 4 heart failure, should not really take this drug or should be monitored very carefully for edema and other issues with volume overload. And finally, this drug does interact with cytochrome P2D6. And again, some of the drugs that I think about in this category, which I'd like to avoid, are the SSRI antidepressants, as well as several beta blockers, as well as ondansetron and metoclopramide that we use as antiemetics very frequently. So I think it's important to keep those in mind. And now I'd like to shift and really talk about some of the bone targeting therapies. What can we do to actually help patients that have bone metastases? As you know, metastases are the most common site of distant disease in patients with advanced prostate cancer. And historically, we've been using the intravenous bisphosphonates, namely zoledronic acid, has been very widely used. And this drug has a lot of benefits. Initially, it was used for osteoporosis prophylaxis in patients that were receiving chronic androgen deprivation therapy. But then in patients that do have bone metastases, it can actually be a treatment of hypercalcemia. It's been shown to prevent fractures and skeletal-related events, as well as possibly relieving bone pain and some quality of life benefits as well. Now, there's some controversy as to whether these agents, bisphosphonates, Zometa in particular, zoledronic acid, has an anti-tumor effect. I think the jury is out there. But there was a pivotal study that I'd like Dr. Sartor to describe, which actually led to the FDA approval of this drug for the prevention of skeletal-related events.
Sure. So this FDA approval actually occurred in 2002, and it was a trial where there were actually 2 doses of zoledronic acid initially, and then it was collapsed into 1. There were some issues at the higher dose that were reduced into the 4 milligram dose. So in the end, you ended up with a combined analysis via the zoledronic acid or placebo, and the primary endpoint was skeletal-related events, fractures, radiation to bone, etc. And the trial was positive, and the FDA approved it. And since about 2002, that's been the standard of care for prevention of SREs.
Thank you. And I think that actually sets the stage for talking about a new agent called denosumab, which actually blocks a molecule called the rank ligand. I think, Dr. Gomella, can you talk to us about the mechanism of action of rank and rank ligand in denosumab?
Well, denosumab is actually a very interesting compound. It interferes with, as you mentioned, the rank ligand. When you have osteoblastic activity and metastatic lesions in the bone, rank ligand activity is enhanced. Rank ligand stimulates osteoclastic activity. Osteoclastic activity causes bone breakdown, so when you use rank ligand the monoclonal antibody form, you interfere with the rank ligand, and in turn you reduce your osteoclastic activity and hopefully strengthen the bone.
And so this actually led to a very important pivotal phase 3 study, which we can hear about from Dr. Sartor.
Well, actually, it's a very simple trial design. I mean, you took the standard of care, which was zoledronic acid, and you took the same endpoints, skeletal-related events, and then you compared the new drug to the old drug. So denosumab versus zoledronic acid, and a very, very large trial, and it turned out that it was positive. So this is recently reported in Lancet. It's been FDA approved now, and the denosumab in terms of prevention of SREs was actually shown to be superior to the older standard zoledronic acid.
And I think that's actually interesting because the study was designed as a non-inferiority study, and not only did it meet that endpoint, but it also met the superiority p-value. So again, sort of lending credence that this drug actually really works, is at least as good, maybe potentially better, perhaps than zoledronic acid. Dr. Gomella, can you talk about some of the adverse events that we're seeing with denosumab in the phase 3 study?
Well, in general, denosumab is a fairly safe drug. We were a little bit disappointed that the osteonecrosis of the jaw was seen in about 2% of the patients. We thought that perhaps with this drug, unlike zoledronic acid, we would not see that. Hypocalcemia is a problem usually seen within the first few months, which is why we recommend that patients undergo supplementation with vitamin D and calcium. Other acute reactions related to the injection of a monoclonal antibody can be seen in up to about 8 to 10% of patients, some fatigue, malaise, and things like that. But in general, with monitoring, it is a very safe drug.
And I'd like to just add some other prescribing information. So the FDA-approved dose for the indication of SRE prevention is actually 120 milligrams given subcutaneously every 4 weeks. And this is marketed as Xgeva, which is different from Prolia or denosumab given for osteoporosis prophylaxis in postmenopausal women. The dose there is actually 60 milligrams subcutaneously every 6 months. As you mentioned, hypocalcemia is one of the side effects, so vitamin D and calcium have to be supplemented. I usually recommend at least 1,000 milligrams of calcium, 400 to 800 of vitamin D in those patients. And in addition, one of the advantages for me is the issue of renal function. So this drug does not need to be monitored. It does not need to be dose adjusted for renal function. And so in those patients with elevated creatinine, this can be a safer drug. In addition, I do recommend that my patients go see a dentist before starting this drug, have an oral exam, see if there's any sort of tooth decay there to prevent the O and J side effect there as well. And I'd like to summarize this section 2 with some key takeaway messages. First of all, progression of castration-resistant prostate cancer might be defined by a number of criteria, PSA criteria, as well as CT criteria, bone scan criteria, and also clinical criteria. Cabazitaxel, as we've just heard, is a novel taxane which was approved specifically in the docetaxel refractory patients. A second drug, which is for the docetaxel refractory population, is abiraterone, an oral agent which blocks androgen synthesis in the adrenal glands and other places. In addition, in terms of targeting bone events, denosumab is a novel osteoclast inhibiting agent that might be superior to zoledronic acid in preventing skeletal-related events in patients with castration-resistant bone metastases. And this concludes section number 2.